of the keratosis. We know that this is of the most common of a benign cutaneous neoplasm. And what is it? Well, it's of that proliferation of those immature the keratinocytes, okay? We can see these things on the face, the back, the chest, the groin. If you are having it, then it can be because mom or dad or other individuals who expose themselves to all of this sun stuff, then that can be something that you are having, okay? One of the most important aspects of the SK, yes, we will chat about another one that is similar a little bit, but remember, this one appears as of a greasy thing. You have that of a stuck on that is out there, okay? The other thing that is good about that is, other than the melanomas of the ABCDEs, we know that this one right here has that well demarcated brown adherent. You'll have some of that elevated lesion, okay, again, of the greasy and of the stuck on. Treatment-wise, we could be doing someone's trying to just keep me, I don't want to go to the PRV. Okay, so we can do some of the treatments out there, right? So we could do the shave biopsy, we can do the cryotherapy, but we can also do the curettage, okay? Prognosis of this stuff is excellent, but of course we want to do those the pathology stuff so that we can make sure that it's not, you know, looks beautiful, but it could be some type of a melanoma, okay? We also discussed one of the last things of that sign, right? So accorded or associated with SK is that lesser tralot sign. And that's just one of the key components that is only seen with of an SK. So that's a rare sign of internal malignancy, that lesser tralot. All right, so that is of the SK. Next, we have that porcelain, right? This one, it can look like some of the keratosis just because of the fact that it's got that same of a name. But it's the stucco, okay? We know that that is what we would see as that white stuff, okay? We know that oftentimes we can see this happen mostly of the down of the dorsal aspect of a foot. We can see on of that shin area. And why is that? Because of the fact that we could have some of a vascular insufficiency associated with this type of the keratosis. Again, talked about the white. It is not always white. It can be some of the skin color, but the key component is that white. We know that because it is one of the keratosis, these are of the hyper of the keratotic of the papules. Just like SK that we just discussed, this one can also have that stuck on, but it's the white stuff and it's on of the ankles of the dorsal aspect of the feet. Not only that, but you can also have it on of the hands, okay? So that's another one of those areas, okay? We don't have to do any type of a treatment here because it's asymptomatic, you know, but some individuals will want it because they're worried about it and, you know, that. But basically, we don't have to do any type of a treatment, okay? What's that one of the other things that we would have to treat though? The insufficiency, right? So we need to have that underlying things that are out there that we have to take care of so that we could get some of this other stuff to go away. DPN, dermatosis papulosa nigra. We know that these things has a predominance of the females, but thank you, Morgan Freeman, because men can have it too, okay? But the predominance is with those of the women. We know that we can see 2 to 3 millimeters of a dome-shaped papules. Usually, this is brown to black, just like that of a stucco. We know that this is a keratotic aspect. Yeah. As we see in that photo right there, usually if we're going to be looking at this, it's on the face. So we can see it bilateral of the cheeks and of the eyes. So it's out over there. Just like of the stucco that we just talked, treatment is not necessary, so it's not something that we would have to do. But if it is desired, then we can do some of a scissor snip, we can do electrocautery, we can do of curette. We know that this is also common, again, with the photo that is up there. So of the Africans, Hispanics, those are some of those things that are out there. All right. Acrocordon, skin tags. What we see in that the photo, pedunculated, right? So it can be of pedunculated, small, or it can be large, like this guy right here. We will see these things happen on the neck. If they're obese, it can be down into that axilla. It can be up and underneath of the belly, right? So they can have it on that waist. We can also have it of the eyelids and the groin and of the buttocks. But those first 3 are one of the ones that we see that most often, okay? Just like what we talked about with the DPN, you either look at it and you see if it's small versus if it's large. So treatment-wise, if it is a small, we can do of a scissor snip, we can do that electrodesiccation, or we can cryo it. Okay? If it's large, like this bad boy over here, then we can use some of the anesthesia and we can excise it. Okay? But oftentimes, they don't look like this one. They often look a little bit smaller. Okay? All right. Dermatofibromas. We know that these things are usually there because of some type of a trauma, right? AKA they were bit by of a bug. They could have of a viral infection. This could be because of the shaving. We can see these things look 3 up to 10 millimeters, slightly raised. Like you can see in that photo right there, it can be pinkish, it can be red, it can be brown, sometimes scaly. Anywhere on the extremities and of the trunk. We will want to biopsy this, again, to rule out melanoma, right? Pretty much going to send them all to path. Biopsy-wise, what's the biopsy that we would do with this one? A punch. And I skipped it, and it's one of the first billets on this damn slide. What is the key component that y'all will see when you are messing with it? Okay? You're going to see that of the dimpling. And what are we going to use so that we see that of the dimpling? Of the thumb and of the index finger. Okay? This is not like of those, neurofibromas, this is in and of itself to see that dimpling. Hypertrophic scar and of a keloid. We know that these things are of that shiny, smooth surface, as you can see in the photos. These things can be due to some of those intralesional steroids that are often used for their atrophic effect on of the scar tissue. So that would be one of those things that we could do. We know that these things, whether or not it is of a keloid or of a scar, these can happen where you've had some of the trauma at, right? So we've talked about the ears, how you can see of a keloid on that just because they're wearing beautiful the earrings. We can also have those things most commonly on a shoulder. Also of the chest or any of that skin surface, but it's most common on the shoulders. So that's that. The keratocanthoma, as seen in that photo right there, we have a dome-shaped red of a tumor with a central hyperkeratotic core. That thing can be filled up. So you're going to see that of a crater, but it can have some of the gunk in it. It can have those things in there that can be easily to get it out. Oftentimes we will see these on the arms, face, chest, trunk, but we can do it on those hands also, and on the hands it's usually associated with the fingers. So it's not just on of the palm or of the dorsal. If these things are on the hands, we'll oftentimes see those into the fingers. One of the things that are specific for this type of a lesion, it is often indistinguishable from SCC, clinical and histologically, okay? So that's one of the key components to this in and of itself, okay? Treatment-wise, we would just actually be doing some type of a surgical excision, okay? So that's that keratocanthoma. Cutaneous horn, those things are beautiful. Looks like they are, yeah, of a witch or something. I don't know. Looks good. White up to yellow. It's hard, just like what we talked about. It can have that of the keratotic of a conical lesion. We could shave this. We could use some of the cryo if it's small, right? If it's got that of a narrow base. But if it's larger, then we could do some excision, okay? Remember, up to 20% of cutaneous horns arise in an in situ or invasive SCC. So this is a predominance of getting into some type of an SCC. In situ. Sebaceous hyperplasia, as seen in though, we know that this is because of some of that sweat areas. Because of that, oftentimes sweat is on of the face, as seen in the photo right there. These things begin as small yellow the papules, like we can see there, and then they become of a dome shaped with central puncta. So they get that umbilication, like of the pinching of the dermatofibroma. So it gets that type in and of itself. Like, you don't have to touch them. It is there. One of that umbilication, we oftentimes know that those are the blood vessels in the valley of that umbilication. Valley. Treatment-wise, electrosurgery, of the shape biopsy, of the curette. But if those things are not working, or you don't want to do them, then let's go ahead and refer them over to DERM for that isotretinoin. So if we want to use something beyond those three that I said, refer to DERM. Visceringoma. So those are that bumps under the eyes. Just like what we talked about with the previous one, this is due to some of that sweat duct of the tumors. Same of the treatments that we just talked about, right? So electrodesiccation of the curettage, of that scissors that are out there. If we decide to shave them, number 11 blade is one of those things to do these serogiomas. But because this is basically bumps under the eyes, let's not shave it, okay? Because it's by the eyes and you're going to make them blind, okay? So that is that. Now, just like the dermatofibromas, we have the neuro ones. Talk about how we can see that buttonhole sign if it's invaginated. So if we are pushing it, then it can, it can take it in. This isn't going to be like dermatofibromas. This is you to push onto it, then you can have it absorb you into there. Again, this is a benign of a tumor that grow on the nerves throughout the body. So it can be anywhere, it's just associated with those nerves. Just like we talked about in that first one of that lesser that one up there. This one has a special name too. This is that of the cafe au lait spot. So that's something cool about it. It can have some coffee. Anyway. Cherry angioma. We spoke about this a lot because we can, see this in ubiquitous individuals that are over the age of 30. Usually we've got that 0.5 up to a 5 millimeter smooth, firm, deep red of the papules. We talked about how sometimes it could be those individuals walking in and saying, what is this? Because I got these, all around of this area. And which areas does it usually, show it at? Well, it's seen on of the trunk. We can see that on of the proximal extremities. So it's not the distal areas, but it's more of the proximal. If we scratch at these things or if we irritate them, then we can see some of the blood that is on its way out. And why is that? Because this is the most common vascular malformation. Okay? So it's most common there. No treatment is required we can just let them know, hey, don't scratch it. Just, yeah. If we're going to have few to many, right? We can shave excision. We can ablate it with that electrocautery. Vascular. Spider angiomas. So you've got that of telangiectasia. So permanently the dilation of those small blood vessels. So it's the spider's feet. Treatment-wise, we're going to do that of the desiccation or laser ablation. So those are the two treatments that we could do with those angiomas. Pyogenic granuloma, that is benign vascular lesion. It's not the most common vascular, because we just talked about that one. But this is of the skin, of the membranes, of mucosal. We can see these in the children, of the young adults. We can also have of the gingiva, lesions in pregnant females. One of the things about this, you can see that on the scalp. It could be on of a finger or of a lip. Slightest trauma causes bleeding that is difficult to control. So we have to be careful with this one specifically so that we don't actually cause it to bleed. So that is pyogenic granuloma. The other things treatment-wise, we know that we could do some of the curettage, but because of the bleed that could happen, electrodesiccation is a better one because it's going to close those blood vessels. So electrodesiccation. And then those lipomas. Really, the only thing that we can do is excise them, right? They are that soft tissue that it feels like of a pillow. It's just that fat. You could move it around so it's not stuck there. You can actually move it around. It is of a subacute lesion, and we know that as of the most common benign soft tissue tumor. Okay? Oftentimes we can see it on extremities, we can see it on the truncal. I was looking at my daughter's pug, and I'm pretty sure that it's a lipoma on her side, but anyways. So, now let's get into some of the good stuff, right? So we're going to talk about these ones a lot. BCC, most common malignant neoplasm in humans, just as seen in those the photos, specifically on that one of that nose. We see that shiny, pearly, firm, dome-shaped papule, and like that picture, we see telangiectasis. So the tele in the BCC is oftentimes seen. Like the picture that is down on the bottom right, it can also have some of that central ulceration. Talked about how it is the most common skin cancer. We can have those of the neoplasms, but it's also of a most common complaint of bleeding. So you scratch at it, it bleeds, and it's just not going away. You can have some of that, the scabbing sore, but mostly it can be asymptomatic. What is the most important risk factor for BCC? That individual has an inability to tan. So that is the most important risk factor. We know that some of the stuff that it's also associated is that sun exposure. But the inability to tan is that of the most important risk factor. Showed y'all, or it's on the slides, one of those of the surgeries that we have to send them over to DERM, and it would be some of the surgical stuff. What's that special one called? Mohs. Okay, so that's where we have to take off that lesion, but we're going to have to reconnect some of that skin, or we could take it from somewhere else and just put it in there. We know how many types of a BCC are there. We have two of those, right? So we have the nodule, and then we can have some of, wait, I just saw the superficial, so okay. It's not two. Let's just go with nodular is the most common one. We're going to talk about those two in a bit. Nodular is the most common type and is most common on the nose. We're going to talk about some of that, the TBSE, so skin examination. If it is BCC and they are looking pretty and there's no recurrence for up to 3 years, then we can stop it. So we don't have to do it anymore if they are the tumor free. So that is BCC. Up next, we have actinic of the keratosis. This could be a precursor to what? SCC, right? So it can jump into there. AK, they have of red, adherent, yellow scales. It feels rough with the palpation. It can feel like of that sandpaper. Just spoke about it, but AK of a precursor, it is equal to of an SCC. So we have to make sure that we're doing that. What if they have of the AK on of their lips? That is called same as actinic, but it is a cheilitis. So like I've called it, is of that of the joker. So it's out of those lower lip area. Usually we can have these things happen on the dorsal aspects of the hands, forearms, and helix of both ears. So that's where we can see these things at. Treatment-wise, if we are going to do the AKs, if there's few of them, then we can cryo them. But if it's multiple lesions, AK5FU, okay? AK5FU. What's that other thing that this can be termed or it can be developed into? Well, that's that CDNH. Chondrodermatitis nodularis helicus. And that is because we can see these things on that superior aspect of the pinna. Okay? So this is CDNH, is a degeneration of underlying collagen superior aspect, like I said, of the pinna, and it hurts. So if we to touch it, or if it's accidentally rubbed, if you're sleeping on that area, then that can irritate it also. So part of the treatment is to give them that special pillow so they can sleep on it and not have it there. Not only of the pillow, but the key of the treatment is to just excise it if it is a CDNH. Bowen's disease. Talked about how oftentimes it can be seen on that the dorsal aspect of a hand, but oftentimes seen on that finger. Okay? What is it? Well, just like we said this earlier with something else, the Bowen's disease, squamous cell of the carcinoma in situ. So that is there. If left untreated, of course, it can now develop into SCC. We can also have something specifically termed due to HPV 8. So we can have that erythroplasia of Curette. So that can be associated with that HPV 8. Treatment-wise, if it's small, then we'll get into some of those other things like electrodesiccation. We can do the curettage, cryo, If it's larger, put that middle finger up and 5FU it, okay? So that's that. And now is the big one. Squamous cell of the carcinoma. We know that sunscreen would be one of those things that we would recommend for the patients to use because it will prevent development of further lesions. This is the second most common skin cancer. With metastatic, so it's going to run around and do those things. This can be caused by radiation burns, irritation, inflammation, immunosuppressive, arsenic exposure. But a big one is an infection of HPV. When we look at these things, we can see it red, scaly, persistent, usually with that deeper involvement it can have of an ulceration, or it cannot. We know that we can have some of these things happen with the things that we just spoke about. So if it starts off as a horn, right? So the cutaneous horn, then it can be SCC, it can be AK, it can be Bowen's. Those things are out there. We know that these things can happen on the scalp, back of the hands, those ears, okay? but it can also happen on the lips. And if it happens onto the lips, you can see that ulcer with of the induration. Okay? Not only that, but it can get up and over, or it gets into that vermilion border because it's on those lips. Treatment wise, we can do excision, but we want to do that with the clear margins because we don't want this to develop into Samoa stuff. We can also, get into the lymph nodes, right? So we want to make sure that it's not spreading around. Unlike BCC, these individuals are going to do that skin examination for life. Okay, so they're going to do that every of the 12 months for life. Now we're getting into some of those neovais. Again, junctional, flat, slightly elevated, and then the compound, it can be slightly elevated, but then into that of a dome. And then of the dermal one, that's a pedunculated dome. It looks like those warty fingers that are jumping out to it. Again, let's just know those things that are specific to those types of the nieva, not the ones that can be back and forth. Congenital. These things, if it is large, melanocytic, most significant risk of a malignant of a formation, right? So these, the parents oftentimes will take the pictures of those things just so they can see if it is developing, if it's getting larger. So if it is, then the most significant risk of malignant transformation. We can see these as of a birthmark, yes, that's there. Speckled lentiginous nevus. So this one right here, it's most common in adolescents. They can have that at birth, or they can have that in infancy. This thing is hairless. It's oval, irregular shaped brown macule. It is asymptomatic, but the thing you can see in that photo is how it is dotted with darker brown to black papular spots. Dotted. Becker's nevus. Unilateral, right? It's not bilateral, this is unilateral. We can usually see this on the upper back, of the shoulder, of the upper arm, chest, so of the submammary. Again, brown macule, it's got a patch of that hair, or it's both. Unilateral. Treatment wise, it's hard, right? Because it's not easy. We can shave it. We can do some of the laser, but oftentimes this is just letting them know it's not horrible, other than you don't like the way that it looks if you go to the beach, okay? Halonevus. This is of that nevus regresses and pigment returns if we're just having it over there. This can be happening over a decade, or it could be happening more than that. One of the things that we did speak about is how it's got that white halo around it. And that was similar to one of the disorders that we talked about in block 2 of the vitiligo. Okay? So this can maybe that herald of an onset of vitiligo. Spitz nevis. This is that benign juvenile melanoma. Oftentimes the parents could bring them in and say, I thought it was a pimple, but it's not going away. Just like that lentiginous, it's hairless. You can have some of that red or reddish, brown, dome-shaped as seen in that picture. There's only one treatment associated with this Spitz nevis, and that's to excise it. We have to send it for pathology to just do that evaluation. So the only treatment for Spitz nevis is to excise it. Blue nevis, slightly elevated, symmetrical, round, regular border, typically less than the 5 millimeters, most common on our extremities, and of the dorsum of hands. Removal is for cosmetic if that patient wants it off, but it doesn't have to be. Magnolian spot, oftentimes seen in that picture. You can see that in the presacral area. You can also have it on of the scalp. You can have it on of the hands, the face, the trunk. But that picture is one of the most common areas that we will see often. Again, asymptomatic, we don't have to do any of those treatments. It happens when they are born, and it'll eventually resolve on its own. Nevis of Oda. We see this on the Asians. We'll see that blue to black, the pigmentation. One of the things that are concerning, are important, that we want to monitor for is if it is located in the area that is seen on that photo. So the trigeminal nerve. So that could be on of the first, it can be on of the second branch. It can also go all the way up into the eye, so we can see that on of the sclera. Because of that, we have to monitor this for glaucoma. So that's one of the things for us to look at. Labial melanotic macule, brown to black macules on of the lower lip, common in young adult women. Looks like of a freckle. Treatment-wise, we can laser it off if they want it, but usually one of the things that we're going to do is cryotherapy for labial melanotic macule. Okay, the wine, port wine stain, commonly involve of the face and of the neck. It's not of a nevis, but it's called that. So think about it more as of that phlemis. So she's got the flame on her face because she spilled the wine. It's not a Nieves, but it is a congenital vascular malformation. Okay. Last one, dysplastic Nieves. We know these are of a male or of a female. It's not just specific. We talked about the pictures of that fried egg. So if it looks like that, then this is what it can be. It can have some of those things that would have us concerned about so that we can work it up, because it'll have ill-defined the borders, margins, pigmentation is varying. Excisional biopsy with the margins if we are suspicious. Individuals who have dysplastic Nieves, we're going to do every 6 up to 12 months of that skin examination. If we're having this, at some of like what we talked about, and we think that it could be some type of a glaucoma, of a precursor, then we would want to do, send them to that specialist, okay? So I have, let's see, that one goes to that. I have 24 slides still left, and I'm getting into all of the malignant melanoma. So let's go ahead and have a break so that I don't put you all to sleep. If you're recording me, then just go ahead and pause it. And then we will have y'all back right at 9 o'clock. Okay? All right, take a break. Do it.
Be honest with yourself. Someday. Probably not today. Probably not today. Probably no. That's fine. Whatever. And I gave you a gift. It was like a reward for my gift. That's what it happened. Get over it. I technically everything I say comes from you. Got me a 90. For the last month, during his review, wrote everything down just like I'm doing now, and then had them side by side, just like stood all the key points. Thank you. I think that might be my first and only contribution.
Baby, whether I should go now or
Sorry, man. I'm sorry about I'm a Falcons fan, so we had a Super Bowl a few years ago. We were here. It never gets better.
The last time that we lost finals, which is the only time, we won the next year right after.
Yeah, at least there's that.
Hoping it's
Dude.
going to be the same.
I mean, it's a bunch of 20-year-olds on the team, so.
Bebes.
take a look.
She likes the price.
The price is good. The Hungarian inside of it is really good. And
I got the torta. Yeah. I stopped for the kids for donuts. Yeah. I judge healthy places.
Well, I don't know if you've been to one of the places. And you can tell that the chat when he's talking about. They're biting on this. Water. 10 seconds before we said that. On our way to the table, water. Wow. I was like, you're doing it right. I know you guys only have like the same ingredients, just displaying it a different way. Thank you for understanding this. You come to dinner, have a European experience, 3 hours. You know, and the European basis of so you go to like go to outside of Spain, which is Spain. Yeah. We tried to do for places too. Like they wouldn't.
So with what I said earlier, and then I actually questioned myself, I was a little bit dumb. Because there are two with the BCC, so I knew that, but I questioned myself. But the most common one is that nodular. So just FYI, because then we can see it over here, how it's of the nose and then of the superficial is of the trunk. So I just looked it up and I was right, damn it. All right, so let's go through these things. Like I said, I have about 24 slides left, and this is us getting into the bad stuff, okay? So we have seen this chart numerous times, okay? A, B, C, D, E. We know everything on the left is benign, and then everything on the right is malignant, okay? So, A, asymmetry. We can see over there where it's not equal on the sides. Border, we can't see it, right? Where is it at? The color, is it all of the same color or no? Diameter is big, and then evolving, okay? So we can see those things are out there. We know that once a lesion begins vertical, growing prognosis worsens, right? We talked about how it can be radial, but once it starts to get vertical, then no bueno, okay? I know that you all have probably already started memorizing A, B, C, D, E's, okay? The ugly duckling. We know that that's one of those things that is showing us how it's different than everything else. It's not looking like stuff in and of itself. It's by itself, the ugly duckling. Malignant melanoma, the Breslow. We know that we have that of the Breslow, but then we also have that other thing known as of that Clark. But the Breslow is a cool one. So usually, if we're talking about malignant melanoma, we know that's usually of the phototypes of what? 1 or 2, okay? We're not going to get it into 5 or 6. You know, we can, but that's acral, which we're going to talk about in a bit. But most common skin phototype 1 or 2. What are we having this? Well, of course, sun exposure, they're having some of the sunburns. Those are risk factors that could actually have this to happen. If we're going to do some type of a workup, if we want to get some of that path, of course, we're going to get in those complete excisions, right? Not only is it of diameter, but it's that of the depth also. We're not going to be doing a shave biopsy. We're not going to be doing those things out there. We want to get into the big stuff, especially with that Breslow of the thickness. Breslow depth is the most important histologic determinant of prognosis. Most important. We talked about some of those phototypes of 1 to 2. That's because they're having some of the UV exposure, but mostly it's that sun exposure. So increased recreational sun exposure is going to be the key risk factor for them. As we are, looking at where these areas could be at, most common for men is on the back, and arms and legs are most common for women. We know that these things, we could be seeing stuff, mouth, nose, eyes, penis, vagina, anus, right? That can be those things out there. 3 labs are on the list of the recommendations to get are the CBC, CMP, UA. So now let's break it into those 4, which are what we are looking for. So superficial spreading melanoma. Most common type of a melanoma is this one. 70% of that, as seen in that of the photo, usually seen as a dark brown nevus on the upper back. Again, most common on upper back. Something that is a hallmark to superficial spreading melanoma, it's absolutely seen in the picture that is right there, and probably some that you will see in your future. The hallmark is haphazard combo of many colors. That's the hallmark of it. This is the most common one, so we will get to see that more frequently. Number 2 is that nodular melanoma. This is completely vertical growth. It doesn't have any of the radial at all. This is just burying itself because it wants to go down deep. We can have this happen anywhere. Most commonly, this is seen as a dark brown, red, black. Yeah, it's everything that we can see inside of that photo. So that's nodular melanoma. Litigo maligna melanoma, okay? This is slow growth. This is those older people, 60s, 70s. They can have this most commonly on their face, but it can also be of that neck and arms. It's brown to black macular pigmentation. 5% risk of becoming invasive. Again, this is a slow progression, slow growth. So that's let it go, okay? Let it go. That's how I remember it. That's easy. All right. Acral lentiginous melanoma. We've talked about this in block 2, specifically for that Hutchinson sign, as seen in the photo. It starts on the proximal of that of the nail, and then it flies all the way up. Okay. The key to this one is most common form in darkly pigmented people. DPP is usually 75% out there, whereas LPPs are like 2 to 8. We can see these things on phalanges, mucus, palms, but one of the things that is oftentimes not seen a lot in those African Americans, those DPPs, is the soles of their feet. They can also, I talked about some of those other things, but it can be face and neck and the chest. Hutchinson's. Very poor prognosis because oftentimes these are not seen for years after years after years. So that's that acral lentiginous melanoma. So that's all of the derm stuff. Now let's get through the room stuff, which is not going to take us a long time. So this is those 11 of the criteria for if we're going to make of a diagnosis. Okay? We know that SLE is an autoimmune disease characterized by potential multi-system involvement and production of an array of autoantibiotics. I'm just scrolling through this stuff. Okay. There are how many types? There are 3. Acute, subacute, and chronic. Each of those things have aspects that are particular to those things, so I could ask you which one it is. Treatment-wise, mainstay and first line of the therapy for most lupus manifestations are those systemic, the corticosteroids. We want to limit those things like we do with everything for a short term. Low dose of the prednisone, reserve of the high doses, and then we're going to taper those things over 3 months. Now, if that stuff isn't working and we need more stuff, then we're going to get into what type of the medications. Immunosuppressants, okay? We said this over and over, and I'm just abbreviating them. AZA, we're going to use that with what? pregnancy because it's not tetragenic. But the next one is tetragenic, so we're not going to do that with a pregnancy individual, and that is MMF. So that's that mycophenolate mofetyl. AZA, yes. MMF, no. Discoid, that's that one of a component of it. So it's got that thickening of that skin that's just happening because that it's, yeah, building itself up. Yeah, I don't have anything else to say. All right, Schrögens. We can see in that picture that we've got those glands. So the most common location of lymphoma is those parotid glands. So that's what we can see there. More stuff about Sjogren's is xerostomia is the key feature in primary SJS. 95% of the patients will have xerostomia. Xerostoma is what? Dry mouth. What could we treat for the dry mouth? The pilocarpine. Okay? That's all I have to say for that one. Scleroderma. Most common cause of death with scleroderma. There are two that are number 1 and number 2. Number 2 is lung disease. What is number 1? Cardiac, right? So heart stuff. Underlying stuff there, we will know that this can either be limited or diffuse. Limited, we could have that skin thickening confined to extremities, distal to the elbows and knees, but it can also have some of that face involvement. 30% of that can also be diffuse, which is of a lower area. So there is skin thickening as well, extending to the proximal portion of extremities. So it's got that trunk involvement. One of the things that we need to be treating is the hypertension. So with that, we would use some of the captopril. Other treatments out there. It's rare, but some of the things that we could be using are the methotrexate, the gabapentin, rituximab, or IVIG. So those are some of the other things out there. Raynaud's, so that red, white, and blue, most likely associated with systemic sclerosis. We can also do anti-nuclear antibodies test, or we can do that nail fold capillary examination if this is Raynaud's. Now we're going to get into these other things, but these are specifically inflammatory muscle diseases. These things all have that proximal muscle weakness and myalgias. We see this heliotrope rash. There are 3 things out there. So we get those gatrons of the papules. We get those other the gatrons. But heliotrope rash I wouldn't say it's a big one, but it's one of those things out there that can be part of a differential diagnosis, because with lupus, they have the malar rash, which is in the kind of the same areas, except for those of the nasolabial areas with the heliotrope rash. Dun, dun, dun. Again, heliotrope rash of the gatron sign, of the gatron of the papules. These are pathognomonic. All three of them are pathognomonic for dermatomyositis. Those three things, dermatomyositis. Gatron's papules are most commonly, which we're going to see this in a picture right after this, it is most commonly seen on the MCP, PIPs, DIPs. So it's on those hands. Gatron's sign, we see erythematous rash involving extensor surfaces. And the one that I told you is important because of the fact that it can be looking like SLE, which is also, some of that stuff, is the heliotrope rash. You're going to get that red or purplish discoloration of the eyelids. This may appear as hyperpigmentation in dark-skinned patients. We can also have the Schall sign, of the V sign. We can see some of the hiker's feet, mechanic hands. Those are things out there also. Medication-wise, because this is inflammatory muscle disease, then we can get into things like prednisone, methotrexate. But we, always have to make sure that we're not pushing them into some other disorders. There's the gatron's papules, again, MCP, DIP, PIP, those hands. V sign, Schall sign, mechanics. Again, I talked of those two medications that we can use. Prednisone is that preferred one. That's the first line. Prednisone. Levato reticularis. We know that that is that reddish, purplish, reticular pattern. So we can see those over there. We can have this happening of some ulcer of the formation. It can be obstruction of those caps. So that's levato. Mononeuritis, multiplex, aka that's that of the foot drop, of the wrist drop. So they're having that of sciatica, of the perineal nerves that are not bueno. So that's what's happening with the picture to the left, and then of the radial nerve on the right. So foot and wrist. Now, one that I talked about a lot, and it's one of those things that you will see. So this is, So first off, if we're doing some of the things that are suspicious or making us wonder, GCA is the most common type of vasculitis in adults. We know that that is that of temporal artery. But the things that are out there and show you or lead you to know that they're having it is they're having some of those other symptoms, such as a new headache, jaw the claudication, scalp tenderness of that temporal artery, we can have some aortic involvement, which may result in asymmetric arm of the pulses. So it's not the same on them both. Another one that is out there that is key: vision, vision, vision. Okay? Because we've got two things out there that would happen whether or not the vision is there or if it's gone away. So, patients with suspected GCA who have experienced transient visual loss for a few hours should be admitted and given high-dose intravenous methylprednisolone. So that is, if they're having vision loss, we're admitting and we're giving them high dose. If they are having none of the vision loss, we can still have the diagnosis of the GCA, but we're going to give them the prednisone and send them on their way. Okay? If they are, regardless of the vision loss or the vision good to go, they'll get into those the medications for a year. Okay, require 1 year if we're prescribing those medications. Scrolling back up. One of the other labs that are out there, again,
Yes, sir.
what's that?
Yes, sir.
ESR. Very good. It's very high. Part of the GCA is we have to monitor that over and over because then it'll lower, lower, lower down, and that helps us know that we're treating it appropriately. Okay? GCA. I like GCA. PAN. So this is the polyarteritis nodosa. This can be refractory to the glucocorticoids. That is equal to cyclophosphamide. So those are those two things out there. PAN can also be associated to Hep B. Okay? Just as seen in the photos, you can have that of the palpable of the purpura. They can have some of the skin ulcers. It can get severe and into gangrene. So that's PAN. We're almost there. So now just breaking it down into some of the things that we could do. Shave biopsy. We want to get the path onto that. We want to remove benign surface neoplasms. So we can use this for SKs, warts, yada yada. We will use this even if they're raised. But only because we do not need to get the full thickness. It's not necessary, okay? If we're going to do of a punch or if we're going to do excision, then we have to take all of that thickness tissue. But with shave biopsy, we can do it if that's not needed. Punch biopsy, okay? We want this for a full thickness specimen. Why? Because we're going to push it down up until we get into that the sub-Q. We'll feel that pop, and then we can raise it up, snip it off, and send it off to path. Usually have these things from 2 up to 8 millimeters, so we just have to pick which one is outside of that size of the lesion so that we can get it. Excisional biopsy. We've got some of these things that will have to be used if we suspect malignant melanoma, if we think that it's of a BCC, SCC, that are deep or nodular. And the last slide. I already told y'all to know where it's at. Are we doing deep and superficial, or we're doing superficial by and of itself? So you will want to know what suture size, suture material, whether it is deep or up top. Okay? That is it, ladies and gentlemen. An hour and a half. That was only 55 slides, and I said every answer.